Hola, buenos días. Matías, buenos
Hola,
días.
hola, hola,
Good,
hola. Juan,
good morning. Yes, good morning, my friend. How are you?
fine, and you?
Hi, Dr. Sol.
Hello.
Yes, and we are okay. I will have the pleasure to tell you that the room is full. We have physicians from multiple countries, and Dr. Apuja Parik will be the moderator of this session. So please go ahead, Puja. Thank you, Matías, and thank you, team.
Great.
Soli.
Greetings from Denver. Can you hear us okay?
Yes, absolutely. We hear you fantastic. And you?
Great. So it is our great pleasure to introduce Dr. Sol Garcia Toro, interventional cardiologist at Sanatorio Pinocchio in Buenos Aires, Argentina, as well as Dr. Matias Stefman, coordinator of interventional cardiology. And they have a wonderful case today of TAVI in a small annulus, which we're excited to see. I'll have you introduce your team.
Hello, how are you? Good morning to everyone. We are very grateful for this opportunity and thank you for the invitation. I like to share our team, our chief, Dr. Stegman, Dr. Dr. Shansi, she's our fellow, our cath lab technician, Soledad, our nurse, Mariela, our technic from Medtronic, Micaela, and then we have the echocardiography's Victoria and Dr. Daru in the anesthesia.
So as you can see, the cat lab is full of women.
It's our reality.
It's our reality.
It's true.
You're getting applause on our end.
Let's go with the case presentation, please. And if you have any question, please let us know.
Good morning, everyone. Today, we will present a live case of TAVI using an Evolut FX platform in a patient with a small aortic annulus. I am Maria Estela Jansi. I am a fellow here at Sanatorio Finocchio, and I am pleased to introduce you to our patient today. Our patient is an 84-year-old woman who has moderate to severe symptomatic aortic stenosis with a speed of 3.4, a mean and peak gradient of 26 and 47, and an aortic valve area of 0.9 square centimeters. Clinically, she presented with dyspnea, an angina in class 3, and the stress echocardiography show a diffuse ST segment depression associated with dyspnea, although without clear evidence of ischemia. Regarding her clinical history, she has multiple cardiovascular risk factors, including hypertension, dyslipidemia, obesity, and a history of smoking, and currently a diagnosis of chronic obstructive pulmonary disease. She had a previous acute coronary syndrome treated with PCI to the LAD, and in 2024 she underwent another complex PCI involving the left main coronary artery, the LAD, and the circumflex artery. That same year, she also required a permanent pacemaker implantation. In her laboratory results, we can see a hemoglobin of 15.8 and an estimated GFR of 49 millimeters per minute. The EKG show a pace rhythm, and in the echo we can see a preserved left ventricular systolic function with an ejection fraction of 53%, with no regional wall motion abnormalities and a moderate to severe aortic stenosis. In the coronary angiography that we performed, we saw that the stents that the patient had are patent, and that there is a chronic total occlusion of the right coronary artery. However, this lesion has no evidence of ischemia in functional testings. The CT analysis revealed an annular perimeter of 71.6 millimeters with an annular area of 391 square millimeters. Annular dimensions were 25 by 21, confirming a small anoval annulus. We also observed that the aortic root has an angulation of 58 degrees and that the coronary heights were adequate. The CT analysis also demonstrates a significant fibrosis and calcification of the aortic sinuses with asymmetric involvement that can contribute to distortion and reduction of the sinus dimensions. We also can say that both femoral axes were suitable for the procedure. So in summary, we have an 84-year-old frail patient with symptomatic aortic stenosis, with previous pacemaker implantation and complex coronary disease, and more important, a small annulus anatomy. The main goal in this patient is to optimize long-term hemodynamic performance while minimizing the risk of prosthesis-patient mismatch. To support valve selection, we review the SMART trial data. At 3 years, Evolut and Sapien show similar major clinical outcomes. However, the Evolut platform demonstrates lower rates of prosthetic valve thrombosis and valve dysfunction. One of the most important findings from the SMART trial was the hemodynamic superiority of the Evolut platform in patients with small annulus. Evolut showed larger effective orifice area, lower mean gradients, and higher DVI values. The SMART trial also demonstrates that Evolut reduced moderate and severe PVM, and this was associated with lower all-cause mortality at 3 years. Therefore, minimizing the prosthesis-patient mismatch was a major factor in the procedural planning for this patient in particular. Taking into account this evidence, we select an Evolut valve for our patient. Then, valve sizing was carefully discussed in this case. With the CT results, the patient was in a borderline zone between Evolut 26 and 29. With a 29 valve, we had a 28% oversizing, and with Evolut 26, a 15%. Considering the anatomy, the prior pacemaker implantation, and the balance between hemodynamics and oversizing, we select the self-expanding supraannular Evolut FX 26 mm valve. Our strategy includes conscious sedation, ultrasound-guided puncture of the right common femoral artery, a secondary right radial access, a pre-dilatation with a 20 mm balloon, an LV wire passing during the deployment of the valve, and the valve implantation using a cups overlap technique. We will do post-dilatation only if it's necessary and a prog-like closure. In conclusion, this case illustrates the importance of individualized valve selection in patients with small annulus. In this anatomy, optimizing hemodynamics and minimizing prosthesis-patient mismatch are central elements in the planning of the procedure. Thank you very much.
Wonderful overview of this case. You bring up this, not just the small annulus, which is such an important topic, but also when we're kind of in between two valve sizes, which, in situations like this, where we're choosing between the 26 and 29, I'll just ask our panel, what are some of the factors that make you think about a 26, for instance, in this case?
Yes. Firstly,
I think like
panel.
Go ahead.
It's okay,
go.
sorry, to have a valve that is fully deployed instead of being constrained. So I think that if the oversize is more than 20%, I tend to take the valve that is under that 20%. So just to make sure that it's fully expanded. What about the audience?
I think if you've got minimal calcification, that would be something, or maybe I would, err on the side of the larger valve if you're, worried about valve migration in that. But yeah, generally speaking, I agree. I'd rather have a fully expanded smaller valve than an underexpanded larger valve.
Right. So the factors leading us towards a smaller would be things like calcification, or if your LVOT narrows a bit. And I think we're in agreement that we would choose the same size that you guys are.
It was very a nice case presentation. What is pushing you to do the pre-dilatation in that specific cases? Do you do it systematically or?
Yes, we usually do it systematically, but in this case, because of the severe fibrosis that we saw in the CT assessment, we decided to do the pre-dilatation. We changed it, and we are going to use a number 28 balloon.
20.
20. 18. 20.
So yeah. As you can see in the CT, there are a lot of fibrosis, and maybe we can go directly, but we have started many years ago going directly. Then we changed predilatation always, and now we are selecting which case predilate or which case no. In this case, we think that the predilatation will help to do not slipper the valve down in the ventricle or up. And as you can say, we select the 26 also because of this. If the oversizing is too much, and also because the 29 is a little bit tapered in comparison with the 26, maybe the migration of the left ventricle is higher with the 29. Obviously, this patient has pacemaker, so there are not a risk of AV blocks. But if the migration goes more than 12 millimeters, there will be paravalvular leak and also some interference with the mitral valve. So if you have any question, let us know. If not, we are going to advance showing what we did so far.
Sounds good.
Okay.
So, Sol, can you show what we did and what is our strategy?
We have, can they see this part? Yes. We have a 14 French sheath in her left femoral artery. We did an echo-guided puncture. We put one proglide. Everything looks good. This is for our main access, okay? And then we have a 6 French sheath in her right radial artery for our secondary artery, okay? Then guided, then can they see the image? Here.
Can we show the fluoroscopy?
This is that one. Guided by the CT assessment, we set up our implant projection to guide us in the deployment.
And then we crossed the aortic valve,
yes.
And we put
pigtail.
We put a pigtail.
No.
Show with
fluoro.
With fluoro.
Yes.
So we have a pigtail into the ventricle.
Yes.
And
we have.
Then we check the valve. So this is the setting. I don't know if you have any doubt about the setting. So it's very minimalistic because the patient has a pacemaker. So what we are going...
Can I ask you?
Yes.
Can you please, Matthias and Sol, emphasize about the echo-guided puncture? And I remember we worked around that from long time ago. So because we have another case, and the number of people who is using echo-guided puncture here is really low. Can you please emphasize why you are doing this and how many of your cases, how percentage of your cases is by echo-guided?
Everyone.
Yes, absolutely. We do all cases echo puncture. The TAVI cases, the coronary cases, non-coronary cases, all structural and coronary cases are echo puncture because two things. One, because it's safety. There are a lot of publications that demonstrate, that are not new, but demonstrate that the rate of complication are low in small and also in large holes. So this is the main reason, because of security. And the second is because in large bore access, you can see exactly the site where you are punching the artery. So if you punch the artery laterally and not are centered in the artery, maybe the complications are higher, the use of proglide are higher. We use only one because we are sure that the puncture is in the site that we want, and there are no calcium there. So it's a mix of analysis between the CT and also the echo-guided. So we focus first in the CT. We make the access in the CT. We see if there are calcification, and then we translate this to the echo. and see if we can puncture in the very safe place. And the other important reason is because our fellows are not well trained in femoral punctures, because we usually do everything in the radial axis. So they don't feel safety when they puncture the artery. So because they have learned echo guidance. So this is the second point.
Do you usually just use one pre-close?
Yeah, it depends of the analysis of the artery. If it's a small artery and there are no calcification, we feel comfortable with one. That is the case. If there are big calcification and we have any doubt if the first proglide has put in place, we use two. But usually we use one. So let's go with the case, if you are agree. Can we show the fluoroscopy and also the hemodynamics, please, in the screen? So
yes. Perfecto.
I want to show the hemodynamics because it's a very strange case, because the patient is symptomatic with no too much gradient, but as you can see in the echo, there are high velocity, not too much. It's a moderate to severe aortic stenosis with moderate gradient, but she is still symptomatic. We treat the coronaries and it's still symptomatic, so we decide to treat the valve. As you can see, there are not so much calcification, but it's fibrosis. So we are going to place the safari wire. Any one of you in the audience has select, in this case, or could select balloon expandable valves, because it has some angulation and it's small, but it's not really small. So we place here. Vamos a la posición de implante. We are going to go to the Caso overlap. Are you agree with this projection? Sol, ponerle la proyección.
Sí, vamos ahí. Es esto.
What do you feel about the projection, Caso overlap projection? No escucho. No escuchamos.
Okay.
That looks like a great cusp overlap view that you have there.
Okay.
There's a little bit of, I mean, I think it's acceptable for a cusp overlap. Maybe some tweaking on the angiogram could overlap them a little bit further.
So let me say something. This we are running one study that is like a cusp overlap study for Latin America. So we are analyzing a lot of patients in Latin America that we implant in cusp overlap, and these patients go to this LATAM registry that is also supported by Medtronic. And the main goal of this study is to see our rate of pacemaker in Latin America using this technique. Juan has pushed a lot for do that, así que so Juan, feel very proud of it. This is a cusp overlap patient that is included in the registry.
Bye.
How many patients do you have enrolled in that registry thus far?
Globally, in all Latin America, we are about 155 maybe, and in this center, 20. So we are going to go with the predilatation. Avanzamos.
Dale.
Vamos con marcapaso 140. Sí. Okay, we are pacing 100. and 40. That is good. As you can see,
Perfecto.
the balloon inflate. Apagamos.
¿Listo?
Properly.
Perfecto.
Everything looks okay. This is a 20 millimeters balloon.
Me equivoqué.
If we need to post-dilate, we are going to do it with 22 or 23, depends of the position of the valve. I will talk more than Sol because Sol is very focused in the case. But if you have to talk with Sol, do it without a problem. She can do, because it's a girl, many things at time, in the same time.
I am a girl.
So let's go with the valve.
Sacando.
So this case is a case in between, 29 or 26. We have discussed a lot, and let's see what happened. But we feel that 26 would go okay. It's effects. Eso te ayuda.
Sí, yo aprieto.
That helps to do it more accurate. Let's see. There are some physicians that choose always the bigger size. I don't know if it's the best practice in this case.
I think we're all in agreement with you here with the 26.
Okay.
Perfecto.
Happy to hear that. So let's talk a little bit about the effects. Everyone is using effects there?
Yes.
Okay.
FX Plus.
FX Plus. So we are in the phase of
¿Estamos bien el flashboard?
Yes.
Sí. Listo.
FX. We don't have FX Plus, but it has changed a lot
Espera, ahí va.
with effects. So our practice here is always to advance with the flash port. ¿Me puedes mostrar las manos? Espera un poquito.
Sí, sí, así mostramos el otro.
With the flash port in our 3. So Sol has advanced through the
En la hecha.
aorta. We are going to pass through the thoracic aorta, and always we go to LAO to see how the valve dive or navigate through the aorta. In this case, we have some angulation, so we are going to proceed very carefully. And as you can see, the hat marker is facing the outer part of the aorta. So we are doing this very, very soft, so the technician moved the flat panel now to the cast overlap projection, and we are going to cross the valve. Estamos en 10-10, vos vas a manejar,
Sí.
Perfecto. So, okay. Vamos a poner el marcapaso. ¿Dónde está? Aquí.
Ahí.
So we are going to start
Bueno,
to see if the projection is okay. Go a little bit
Sí.
deep. And as you can see, there are not
menos.
linear mark. So now we are trying to alienate, poner más caudal, to make a linear. This is a line. Okay, so we have 3 points and a line. The patient is very stable. So let's do an angio there.
Ahí, vamos.
Okay.
So does the fact that this patient already has a pacemaker affect your depth decision?
Absolutely. We are not going to go very high. So vamos un poquito más abajo.
Okay.
At this point, I will hold the wire, and Sol is going to push a little bit. Perfect.
Ahí va.
And I will start to open to see how it behaves. The patient is very stable. Okay. Vamos a hacer un cine ahí. We are not going to go too high. I like. If it's deep, it's okay. So we are going to start with the pacemaker because it's a good projection. Guarda, coleco. Ahora, when the patient take a deep breath, the valves go up. Vamos un poquito más abajo.
Estoy empujando.
Test. Okay. So we are very stable.
Bien.
Ok, bajamos a 100. Okay. As you can see, the valve is deployed, but it's not aligned, so we have a lot of parallax. Vamos a tratar de alinear la válvula. So the valve behaves very stable. Andate un poquito más hacia la derecha. Ok. Y un poco más craneal.
Pacer, Matías, pacer on.
Pace out. Juan, we are hearing you. Vamos más caudal. Más caudal. We are trying to alienate the dots. It's very helpful, the effects here. Empuja un poquito. Vamos más caudal. Más caudal. Ok. Un poquito más. Ahí. Let's see. Let's see the projection. Let's see the implantation. Dale,
¿Sí?
vamos.
Voy.
Okay, so Sol is...
Any thoughts from our panel in terms of the depth here? We like it?
Yeah, I think it's okay. You're probably 2 to 3 on the non. I think that looks good.
Right, I would agree. So you look like you're close to 2 to 3 on the non here. And the dots here clearly display that, you're either at or below the base of the annulus.
Can we
So-
take a view in the cusp overlap view? Because that's going to give you your most accurate assessment of depth. As soon as you deviate from the S curve, then we don't truly know what our depth is.
Vamos a la posición de implante. Yes, yes, yes. We are going to do that, but as you can see, the dots will be very not alineated.
Sí, no te preocupes.
Hacer un
Ahí,
cine.
dale.
Here we can see that the depth is okay, but the 3 dots are
Not
with
aligned.
too much parallax. If you agree, we are going to go to LAO. Vamos a una izquierda.
I think your depth on here looks fine on the non. I think going over to LAO is fine here, just to reassess what your left depth is.
Más caudal. Ok.
Está perfecto.
Dame un campo más.
Eso.
This is our regular practice. We go to LAO always. Dale.
Cine.
Okay. What do you think? I think that looks okay.
Yes, it's 2 millimeters.
Looks very
Vote
good.
from the audience. Everybody likes it. Anyone would retrieve here? No?
Please.
You're getting thumbs up across the board here.
Okay.
Yeah, this is Kendra.
So-
That looks fantastic.
What important thing, we are going to put the pacing at 140 or 20, 120 to try to avoid any extra beeps.
Mati, in the meantime that you are doing this, I would love to clarify a concept. And Kendra, please help me if you like. So remember that for depth assessment, the only thing that you need to do in the non is checking the non.
Empuja un poco.
You don't need to change the parallax. You don't need to make the dots align. To assess depth, the only thing that you want to see is what's happened in the valve, in the frame of the valve, close to the non, close to the pigtail. That's the only thing that you need to do. Don't even look about the other dots, if they are aligned, the parallax is there. This is just
Listo.
statics that they are not related
Vamos
with
a
the
la...
depth. And then when you move to LAO, you check exactly
LAO.
the same thing. Don't take a look about the alignation of the 3 dots. This is totally different things because it's depth in the non and depth in the left. If you want to see later, that's for
Okay.
pictures, you can align the dots, whatever to see, but not for the non and left. So, because in past case also, I saw Andrejka make a comment about alienating the dots, but this is not totally right. So for depth, just take a look in the cusp overlap, LAO, just the non for the non, just the LAO for the LAO, LCC for LAO.
Yeah, the only thing I would add is that remember that the dots are for commissure alignment. They do add a visual cue for what the depth is, but you're looking at the frame on your S-curve in the non to assess depth. As soon as you deviate for that, you introduced error in your depth assessment.
Okay, yeah, it's very nice information. So we have did only a fluoro to show you the dots and the valve related with the pigtail. I think that the projection and also the height is nice. Sol is pulling up the pigtail very gently and softly. And we are going to assess, ponete ahí en la copa, we are going to assess leak or something like that, con la cuerda.
Sí.
Ok.
Listo. Ahí.
Déjame ver.
¿Quieres verlo más?
Vamos a ir un poquito más.
Más adentro.
Oh, ahí.
Menos gently.
Baja con las dos manos.
Voy.
Perfecto. Dale.
Just a question in the meantime, Kendra. Like if you try to align, so are you always able to align the three dots, or if it's not aligned, like it's a sign that the valve can be distorted or something about the frame?
So it's about what question you're asking, right? And so when you're in your cusp overlap view and you're on your predetermined S-curve, anytime you deviate 10 degrees, you're off by 1 millimeter on your depth. So let's just be clear. If you straighten out the valve and straighten out the dots and you move 10 degrees, you've changed your depth of implant, what your assessment is by 1 millimeter. So you no longer know where you are in space. So the first question you ask once your valve is at 80% is, what's my depth on the non while I'm on the S-curve, no matter where your dots are. Then also on your S-curve, you're going to look at your dots, making sure 2 on the left, 1 on the right. That's going to tell you coronary alignment of the valve. Manipulating anywhere from there isn't going to really answer a question. Straightening out the dots in a straight line doesn't really answer the question. When you move to LAO, we saw a first case yesterday where they used an isolated left. Follows your S-curve, lined up your dots the other way on your CT, so you had an isolated left. That's the only way you're going to truly assess real depth of implant on the left. If you just, as our training materials say, go 25 L from your cusp overlap view, you aren't on the S-curve, but it's going to tell you, am I above or below the annulus? And that's the only question that you need to answer. And then am I dramatically above or below? So the question of lining up the dots, taking the parallax out, it doesn't really answer anything specific of what's my depth on the non, and do I have commercial alignment? Those are the two things I'm concerned with.
Yeah.
And let me finalize the concept. But the annulus is a elliptical shape. So imagine an ellipse shape in your mind, like in 3D way. So the dots are in different heights because you are seeing a 3D structure in a 2D plane. That's why everything is distorted. If you want to align them just for the picture, you don't know where you are. You are creating, it's basically going back when we do the initial coplanar tree cusp view that we believe, oh, we are right, but we are totally wrong.
Hagamos una... So, Juan and all the panel, this is the final ansio, and can we see the fluoro for a minute? Pone fluoroscopía. So this is the final fluoroscopy. I think that the leak is almost nothing with the wire inside, and the position of the valve is really nice, and also we assure that the selection that Sol did, because Sol was very involved in the selection, and also the fellows here are involved in the selection of the device and the size of the device, because are measuring all the cases. So this is a good result and a good valve selection for this lady. So if you are agree, we are going to check by echo. That is also our practice here until we left the cath lab.
It looks wonderful on angio, so we'll see what you get for your hemodynamics.
So Vicky is our echographist. She's trying to find a good window. But Vicky, what do you think in terms of leak? Mostra una imagen. She do not see nothing in terms of leak, and also the valve expansion looks great. Sol,
Everything
what do you
looks.
think?
I thought that we should, not now, and I thought that we was going to need post dilatation, and it's perfect. So I am really happy.
Yeah, we are not going to post dilate.
No.
What do you think about the
What's your
coronary
threshold?
access? Coronary access in this lady.
So your threshold for post-dilating, would that just be moderate PVL, or would you even consider it for mild?
Mild.
Yes, mine, not less.
With mild we do.
Yes, but it's not the case.
But in this case, by
Any thoughts from the
yeah, sorry.
any thoughts from the audience? Do you? I mean, I know there are other factors involved, age and maybe how much calcium burden you're dealing with there, but for us, we typically do definitely do moderate or higher, but mild is sometimes a question in terms of whether we choose to pursue that or not for the post-dilatation. Do you guys have the same practice?
Yeah, I would say I'm probably 50-50 on post-dilating for mild. If it's a young patient and there's not a ton of calcium in the annulus or LVOT, I probably will. But if there's anything that, gives me pause about going in with a non-compliant balloon afterwards, then I won't.
It's interesting now that the TVT registry puts this as a publicly reported metric as well, right? Moderate or severe paravalvular leak, you get dinged for that, and so most certainly all moderates would get addressed with post-dilatation. But again, the mild tends to get overlooked in some situations, especially if they're significantly older or if there's a lot of bulky calcium there. Or if you have a higher implant where you might be concerned with post-dilating and any sort of risk of movement of that valve.
I think that it depends the age of the patient, also the position of the valve. There are some positions, some valves that you are going to be penalized if post-delayed because they are so high. But in terms of result, if the valve, the position is okay and we have some opportunity to have a better outcomes, if we have mild to moderate, we do the post dilatation. But depends on the case.
It's interesting here with closure. While we see pretty much everybody is using, ultrasound guided micropuncture access, with closure there's a lot of variation, right? I think I use 2 per closes for the most part. I know some like to use 1 per close, some like to use 1 per close with an angioseal. Some institutions also use a manta. Are there people who deviate from the 2 per closes or do something different in the audience here?
My service is 100% public, so most of the times we use just 1 per close. We just put the second one when we see that it's good with just 1. But then in a private service, we actually use 2 per close. And I don't have a good experience with put the second per close after sometimes, and the angioseal after. I prefer start it with 2. And but in private, in the sorry, in a public hospital, we actually do just one, and the second one if it's necessary.
I see. Is anyone doing radial for the pigtail? Have you found that it's been helpful in terms of bleeding rates with?
I think the challenge with using your pigtail via radials, if you need to fix the groin, if you need to balloon it or stent it or anything, it makes it more difficult. It's not impossible, right? I mean, you can put an R2P sheath in that, but it definitely makes it more challenging.
It's funny, I almost find like it seems like if there's ever a vascular complication, it's always on the non-valve side, right? It's always like a tiny pseudo or something on the non-valve side. And so maybe maybe thinking a push for more radial in the future.
When we do the alternative access, we always use the radial for the pigtail so they can mobilize immediately after.
Oh, that's great.
Yeah, in the case that we have a big complication that we need to put place a stent, we have the echo here, we make the puncture in the other side echo guided, so we are going to be very sure that the puncture is in the femoral, and we trying to solve the problem by collateral femoral access. But honestly, as you say, we usually see the complications in the non-main axis of the TAVI.
We started to use the Menta and we stopped. Like the rate of vascular complication increased. I reopened the growing and the plug was always like not on top of the artery. Like, so we changed back to per close.
It's a lot of money and a lot of cost of outcome.
I have a question about the pacing, because both of these cases, they're pacing over the wire, which is great. What is everyone's strategy if you do pace over the wire? You have a new left bundle, self-expanding valve. Do you do an active fixation or through the leg to the ICU?
So the question actually, perhaps you can answer, Dr. Matez, if in these situations where you have LV pacing over the wire and you have a conduction disturbance that you're seeing, what is your strategy in terms of going forward with either putting in a TVP from the groin or just calling EP to?
Yeah. If the conduction disturbance is only LV block,
AV.
Left bundle branch block, we go without to the ICU for 24 hours without pacemaker in the right cavity. But if the patient do a total AV block during the procedure, yes, we put a 24 hours pacemaker and we see what happened in the next day. Usually we see that all the conduction disturbances, if the valve goes in the perfect position, disappear in 24 hours. So we are, in fact, you are going to see in the registry, but we are having better results in terms of conduction disturbance using Evolut than balloon expansible valves. That is because we have learned how to manage, how to wait, how to put the valve, and obviously when we have to be very aggressive with the indication of the pacemaker or when we can wait. When you have AV block with balloon expansible valves, there are not, it's not reversible. We have seen so many, not too much patients, very low quantity of patients that reverse the conduction disturbance. With self-expandable, with Evolut, the rate of reversion in 24 hours is very high.
Matthias, that's what we saw in the Optimized Pro study as well, is that most left bundles resolved and that very few went on to actually require pacemakers if they were monitored. Whether or not you monitor in the ICU or on a telemetry floor is institutionally dependent, and we found that too in the Optimized Pro study. But what he just described, and this case is a great demonstration, is that the proper landing of the valve and that positioning, it's really with the target to be 3 millimeters, that's going to be the biggest determinant. Just for awareness, for those of you who are not in Paris, Danny DeVere presented and then subsequently published in JACC Intervention just this past week, looking specifically at the depth of implant. And if you did a good pre-dill, as what was described here or demonstrated here, and then landed more shallowly, then you had fewer recaptures, you had no migrations or pop-outs, and his pacemaker rate and the highest valves was 3%. So I think that there is something to this high implants technique, and we're seeing that what we found in Optimized Pro and then the FX addendum with the new stability layer is what you're seeing here in this case demonstrated. This was beautifully done. Matthias, thank you so much. Thank you to the entire team, Sol as well. Thank you for taking us through this. Any final comments about how this patient will continue at your hospital in terms of where will they recover, when do you expect them to go home, and then what their follow-up will be?
Ok. ¿Y el último CT que tenías de cuánto era? De 300.
So, if we have time, just to show what is happening, let me know, and I will explain.
Yes, you have time, but also can you address how this patient will recover at your facility? Will they go to telemetry or to the ICU? When will you send them home?
Okay. Usually we go to, in this patient that has pacemaker, so the conduction disturbance is not a problem, we'll go to telemetry until tomorrow. And tomorrow we'll be discharged very early. And this is our practice. Obviously, we are going to check the punctures and the echo. We have did an echo, and usually we do an echo the next day because of we have to take this data. But usually this kind of patient, and also if the patient has not pacemaker, definitive pacemaker, but there are not any conduction disturbance, if the conduction disturbance improve at the next day, we discharge, and it's the same management. So this is the usually management. So now we are focusing in the access because it has decreased the bleed a little too much, but there are some bleed, so we are going to add another ProGlide as bailout. A ver, vamos a ver. Solta. As you can see, there are some bleeding. Yeah, it's not too much, but
we're going to let you guys finish there in Argentina, and we're going to let us know how the patient does. And thank you so much for showing this wonderful case of the small annuli patient with us here in Colorado.
Okay.
Thank you.
Thank you very much for everyone.
Thank you. For us, it was a pleasure.
Recording stopped.